Polyuria. Letter of Referral. Dear Dr. Mrs. Jane Perry, aged 53 years. Thank you for seeing this hotel receptionist who has recently been troubled by passing excessive amounts of urine. She is very thirsty and drinking gallons of water every day. Her migraine also seems to have returned of late, although she thinks that the headaches are somewhat different to previously. Her past medical history includes a left mastectomy followed by radiotherapy 4 years ago for breast cancer. She is on tamoxifen and co-codamol. On examination she appeared somewhat anxious, but there was nothing else of note except for a slightly high BP of 148/93 mmHg. She has a normal fasting glucose level, and her electrolytes and creatinine are also normal. I am not sure as to the cause of her polyuria and would appreciate your advice regarding further investigations and management. Yours sincerely. Introduction. Polyuria is defined as the passage of an abnormally large volume of urine and must be distinguished from frequency of micturition. It is usually taken to indicate the passage of at least 3 L in 24 hours, a useful surrogate marker being nocturia on 2 or more occasions each night. If polyuria is confirmed, there are a large number of possible causes, and the history, clinical examination, and initial investigations should be used to direct more detailed study. In essence, diabetes mellitus, DM, chronic renal failure, CRF, and use of diuretics should be excluded before distinguishing between hypothalamic/pituitary, often referred to simply as hypothalamic, or nephrogenic diabetes insipidus, D, and primary polydipsia, dipsogenic D, with water intoxication. History of the presenting problem. The first requirement is to be sure that polyuria really is present. Investigation for a problem that the patient does not have is futile. If there is any doubt, a 24-hour urine collection should be performed before embarking on other tests. The patient does not have polyuria if all the urine fits in one of the standard containers, although he or she may have the frequency associated with it. Polyuria or frequency of micturition. Tell me about a typical day. For instance, how was it yesterday, starting with when you woke up in the morning? Inquire about the frequency of visits to the toilet and roughly how much urine is passed on each occasion, small, medium, or large amounts. How often does she wake up to pass urine during a typical night? If she can sleep undisturbed for 8 hours, then it is unlikely that she has primary polyuria. Does it hurt or burn when passing urine? Is there any accompanying discomfort in the abdomen/loin/groin areas? All of these might point to a chronic urinary tract infection leading to urinary frequency. Daily fluid intake. In all cases, take a careful history of drinking behavior. Exactly what did the patient have to drink yesterday, and why did she drink it? It is not at all uncommon for someone referred with polyuria to have drunk several cups of tea and/or coffee, 1 to 2 cans of fizzy drink and 0.5 L of water before lunch, the reason being recognized by them as habit rather than thirst, but often also driven by a belief that it is good to keep the kidneys flushed. However, even in cases where it seems immediately apparent that excessive fluid intake out of habit is the reason for polyuria, it is appropriate to look for evidence on history, examination, and simple testing of the other conditions listed in, since it can be difficult to know which came first, the polydipsia or polyuria, the chicken or the egg. Thirst. Is the patient drinking because of a genuine thirst rather than because of a dry mouth such as that experienced with a head cold and compensatory mouth breathing? Patients with primary polyuria drink water/fluids to quench their thirst rather than as a matter of habit or routine. Does she have to get up and drink water, rather than just to pass urine, during the night? If so, this suggests that the problem is not psychogenic. Common causes of polyuria. Ask directly about DM, already excluded in this case, CRF, and use of diuretics. Hypothalamic or nephrogenic D. Questions should be directed at screening for these disorders, for example when considering pituitary dysfunction, a history of head injury, surgery, or radiotherapy should be sought, together with evidence of anterior pituitary failure, lassitude, weight gain, cold intolerance, constipation, diminished libido. Primary polydipsia, dipsogenic D. Compulsive water intoxication, rather than simple habitual non-psychiatric excessive drinking, is likely to be concealed and details may need to be sought from a relative, partner or carer, possible in routine practice, but not in PACEs. Other relevant history. Headaches. Although the patient has a history of migraine, the letter from the GP says that the current headaches are probably different from those that she experienced in the past, which may suggest alternative pathology. In which part of the head are the headaches localized? Are they constant or intermittent? Is there any visual disturbance? Are there any other features such as nausea, vomiting, aura or flashing lights? Patients with pituitary/peripituitary pathology may have frontal headaches, behind the eyes, bitemporal hemianopia, and or visual disturbance due to involvement of cranial nerves 3, 4 and 6. Past history of breast cancer. Lung and breast cancers may metastasize to the pituitary and cause central D. Are there any features that might suggest local or metastatic recurrence? Psychiatric and drug history. When taking a history from patients with polyuria, ask directly if they have any psychiatric history or if they have taken lithium in the past. They may not volunteer this information unless asked directly. Primary polydipsia is most commonly seen in those with a history of psychiatric illness. Lithium, a cause of nephrogenic D, is often used in the treatment of bipolar affective disorders and depression. Plan for investigation and management. Explain to the patient that under normal circumstances you would examine her, and then proceed as follows. Investigation of polyuria. Confirm that polyuria is present before embarking on tests, if necessary with 24-hour urine collection. Exclude osmotic diuresis, high glucose. Exclude CRF, high creatinine and urea. Consider hypothalamic or nephrogenic D. Consider primary polydipsia, dipsogenic D. Routine tests. FBC, anemia. Electrolytes and renal function, dehydration, hypokaliemia, CRF. Blood glucose, DM. Liver and bone biochemistry, specifically calcium, phosphate, and alkaline phosphatase. Urinalysis for glycosuria, DM or renal disease, hematuria, and proteinuria. CXR for evidence of granulomatous disease, e.g. sarcoidosis, tuberculosis, or possible metastases, particularly relevant in this case. Further tests. These include plasma and urine osmolality and the water deprivation test. Having excluded an osmotic basis for polyuria, the diagnosis now rests between hypothalamic or nephrogenic D and primary polydipsia. Begin with spot tests of plasma and urine osmolality. Plasma osmolality, usually lower than 290 mmol/kg in polydipsia, reflecting volume overload, and greater than normal in hypothalamic or nephrogenic D, reflecting volume depletion. Urine osmolality, on the first voided sample of the day, especially if the patient has not drunk excessively overnight, may prevent the need for more detailed investigation. A value greater than 750 mmol/kg excludes significant D. However, often these initial spot results are inconclusive, and it is necessary to proceed to either a water deprivation test or hypertonic saline infusion with measurement of plasma antidiuretic hormone, vasopressin. If hypothalamic/pituitary D is confirmed, the pituitary and hypothalamus should be imaged by MRI and dynamic tests of pituitary function should be considered. Patients with nephrogenic D require more detailed tests of renal tubular function. Management. Excessive drinking. Patients who have simply got into the habit of drinking excessively should be reassured after simple screening that there is nothing seriously wrong and that their urinary volume, and any attendant embarrassment caused by the need for frequent micturition, will be eased if they can gradually decrease the amount of fluid they drink. Hypothalamic/pituitary D. Symptomatic relief may be provided with the synthetic vasopressin analog desmopressin. This can be administered orally, or more conveniently via a nasal spray. Any associated anterior pituitary failure should also be corrected with appropriate hormone replacement. If imaging reveals a structural abnormality, then specific treatment may be required, e.g. radiotherapy or chemotherapy for a patient with known metastatic breast carcinoma. Nephrogenic D. Wherever possible, correct the underlying cause, e.g. electrolyte disturbances. In cases where a reversible cause cannot be identified, thiazide diuretics, e.g. hydrochlorothiazide, in combination with mild sodium restriction are often effective. Amiloride may be of benefit, especially in lithium-induced D. Primary polydipsia, dipsogenic D, in psychiatric disorders. Polyuria can be controlled by limiting fluid intake, but this is easier said than done. Patients may have a known psychiatric disorder, and formal psychiatric input should be considered in those who do not. However, the reason for trying to restrain drinking and polyuria in this condition needs to be considered. Unless of massive degree, it is likely that the only complication of primary polydipsia is the inconvenience of urinary frequency, and reassurance to the patient, relatives, and carers that there is no serious pathology may be the limit of useful medical contribution. Further discussion. Pituitary metastases from lung, breast, and other malignancies are well recognized, and occasionally D may be the presenting manifestation. There may be accompanying symptoms and signs due to local mass effect, including optic chiasmal compression or cranial nerve palsies. MRI/CT does not always distinguish between metastases and other pituitary lesions, but it is worth noting that pituitary adenoma itself rarely presents with D. Accordingly, in a patient with hypothalamic D and a pituitary fossa lesion, it is important to consider other possible diagnoses, e.g. intracellular craniopharyngioma, metastasis, infiltration. If there are no other obvious pointers to the diagnosis, then pituitary exploration and biopsy may be necessary.